As a GP, it's always frustrated me that mental health research tends to focus on individual interventions, a medication, an online module, a focused psychological strategy, but never what works over time. So I'm so grateful for ACT Health's Research and Innovation Fund and their faith in me and my team to look longitudinally across the experience of young people and their GPs over a year of care. We knew it would take diversity to explore diversity, and so we built a team with multidisciplinary perspectives, a variety of carer and consumer lived experience, different ages, roles, identities, and marginalisations. As mental health workers, we knew that who we were was just as important as what we do. We felt the same as researchers. There is no way we would have got young people to engage deeply if we couldn't establish ourselves as compassionate and trustworthy witnesses. Jamila, our young social work student, who's now a fully fledged clinician, was critical, being the main safe point of contact for participants, maintaining relationships throughout the project, and organising times and places to meet that felt right for participants. We surrounded our team with a young person's reference group, and they taught us a lot about current experiences and preferences of their generation. And we also surrounded ourselves with an experienced steering group of experts. So, what did we find? Well, firstly, we needed to acknowledge the shifts that occur in the therapeutic relationship over time. We interviewed 15 young people and their GPs over 12 months of their care. We recruited predominantly through GPs because we wanted to ensure the young people we interviewed were competent to consent and stable enough to talk to the researchers about their experiences. The young people we met had a variety of ages, identities, experiences and marginalisations and relied on a variety of services. They were remarkably articulate and generous with their time. We met in parks, in shopping centres, schools and libraries all over Canberra and nearby New South Wales. We bought a lot of coffee, snacks and pizza, and we made sure they got home safely with Uber vouchers. We even chatted as we pushed a baby around the park, and yes, we gave them vouchers to recognise the importance of their time. We also met their GPs, who were rather surprised to be paid for their time. They were also remarkably generous. We knew that recruiting this way meant we interviewed the best of the GPs with the best therapeutic relationships with young people, but we thought that was a positive thing. After all, we were trying to understand what works well as what doesn't. Young people who access mental health services often started with a therapist or a counsellor or a service as a child, and they told us that those relationships were often dominated by their parents. Some felt marginalised by that, telling us that the problem started because of the relationships they had at home. So having their parents as part of the therapy meant they didn't feel safe talking to their therapists about their own experience. By the time we were interviewing them, most had progressed to a point where they were seeing someone on their own, although their parents were often facilitating those relationships, coming into the consultation at the beginning or end and paying for the therapy. Young people talked about how difficult it was to learn to manage that consultation alone, including how to choose a therapist, get to an appointment, set the agenda, and where necessary, to leave. The GPs talked about scaffolding that transition, helping young people move towards independent consultations and improving their health literacy by teaching them how to access and use health services effectively. I wanted to talk in this session about what matters in that critical relationship. One of our participants had a wonderfully creative way of explaining this. Sometimes, they said, it's like you go to these places that are supposed to provide evidence-based care, and you take this precious vase full of all your previous experiences and thoughts and memories, and you gently hand it over to the therapist. And they take it and put it on a shelf and they follow a manual. When they see this, they never go back. In fact, this same participant was rather scathing about outcome tools, which I'll talk about in the next session. What makes Headspace so needy, they said. I mean, every time you go there, you have to fill out forms to say how fabulous they are. I reckon they have unstable attachment. I do see what they mean. What they want is an authentic relationship. They need to know they're relating to a human. I need to know the person with me is a person, one of our participants said. Like, not in a creepy way though. Like my first psychologist, I remember her telling me she got anxious when she was my age, and it made me feel like she really understood me. We know that from the educational research that young people learn best from teachers they respect in a community environment. They need to know they're seen and heard and understood, and this means finding their tribe. Developmentally, they're learning who they are and who they want to be. The people providing care need to do what teachers do, balance evidence with individual attention, which made us think about what it meant to have their GPs. We became aware that these GPs created a sort of circle of security for the young people we interviewed. They lent trust to the person that they referred to and helped the young person break the ice with the new therapist. The GPs talked about setting up that relationship by sharing what they know about the person and why they think it might be a good fit. They also saw them afterwards because sometimes relationships don't work out. In a way, they held a safe haven for the young person to make sense of this new relationship and way of working. Relationships weren't the only thing we explored in this study. It's an adolescent's job to individuate, to find the adult self they want to be. Mental illness can affect your identity because it affects the way you see yourself as a person. Adolescents have always needed to explore identity and meaning, and we need to give them the space to do so. In my view, it's quite arrogant to imagine yesterday's evidence in today's guidelines can dictate how a young person should shape themselves for a future we can't imagine. Part of our role as clinicians is to teach, to help our patients learn about themselves, their illnesses, and their options around therapy. There is an existing PDHPE curriculum that shapes a young person's understanding of mental health. We should collaborate with teachers so that health and education fit together. And finally, if you have a young person who wants to earn a precious place in health services, they will revert to the skills they have. They will try to work out the rubric behind admission criteria using their peer network, and they will perform the best way they know how to get the outcome that they want. So what does this mean for objective outcome tools? Are they just communication tools? They're unlikely to be objective when a young person definitely wants to be a successful candidate for care. I'm presenting more detailed findings in the next session at 11, but if you can't make it and you're interested, I've put a recording of both consultations on my website, which you can access using this QR code or URL. It's certainly been a fascinating journey.